Hello, future nurses. This is Professor Flourish. Today we're going to be talking about our autoimmune disorders with a focus on the neuroautoimmune disorders. The first one we're going to be talking about is multiple sclerosis. So multiple sclerosis is a chronic neurological disorder that affects the brain, spinal cord, and optic nerves. It's an autoimmune inflammatory disorder that causes demyelination and damage to the myelin of the CNS. So the myelin sheath is this thing that basically covers the nerve fibers. And if you remember from what I talked about when we went into our neuro lecture, this myelin sheath basically acts like, it's kind of like, you know, on the charger of your phone, how they've got that area that covers the actual charge. And if your charger gets broken, then you see a lot of wires coming out. Well, that's basically what the myelin sheath acts as. It covers this fiber, this nerve fiber. So when it gets damaged, then we're no longer having a very good electrical impulse. And that's really what the problem is here with multiple sclerosis, is they're not having that good impulse. It's a progressive disorder and eventually results in central nervous system damage and neurological disability. Like most of our autoimmune disorders, it's characterized by remissions and exacerbations. So you have episodes where the patient does very, very well, which we would consider in remission, and then episodes where it's exacerbated or they have this flare up. The etiology is unknown, and both sensory and motor neurons are affected. So both sensory and motor neurons are affected, which basically means that whether it's the ability to touch or the ability to feel, it's going to be affected. Your treatment includes your immunomodulators and your corticosteroid steroids. So like most of our autoimmune disorders, you've heard me say this a lot, is it has to do with those corticosteroid steroids as treatment. Now, the type of corticosteroid steroids we have, we'll talk about when we get into our medications, but a lot of these, it is that steroids, that way we can hopefully decrease the inflammatory response. So our symptoms. So on here, we've got our most common symptoms as well as our initial symptoms, severe, and then things to look for. So our most common symptoms are basically that progressive weakness in extremities, numbness and tingling sensations, balance problems, blurred vision or double vision, bowel and bladder dysfunctions, and fatigue. Now with it, initially what they're going to be presented with a lot of times are signs caused by damage to the cerebellar nerves. And if you remember what your cerebellum does, it kind of makes it easier to think about these initial issues. Because remember, your cerebellum, it focuses on coordination. So if you've got nerve damage to the cerebellum, then what we're going to see is coordination problems. And you see those in things like ataxia. So ataxia is that inability to kind of do finger to nose, finger to hand. Then you see tremors of the large and small muscle groups, and dysarthria. So dysarthria is slurred speech or difficulty speaking. Now with that, what will happen is, what happens to the patient is they lose coordination with the ability to move their tongue at the rate to which they want to speak. So that's where you see that slurred speech initially. Severe motor damage typically occurs later in disease. So these are the ones that occur later. These symptoms include things like hemiparesis, paraparesis, quadriparesis. Dysphagia occurs also in the later stages of the illness, increasing the risk of aspiration pneumonia. So with these patients, it's very important that we always test the gag reflex prior to feeding them. Some of your cognitive symptoms are things like affects recent memory, abstract reasoning, attention, and visual spatial perception. So these are all our cognitive, because remember, it affects both sensory as well as motor. So these people tend to lose their ability to kind of have a good memory. So some of our diagnostics are manifestation patterns. So if they notice that the patient is slurring, or if they notice that the patient has that ataxia, double vision, or anything of that nature, it kind of helps with the diagnostics. They can also do an MRI, and then they've got a cerebral spinal fluid analysis, which will show increased numbers of your T lymphocytes, and then they can do a CT scan of the brain. So your medications, you've got adrenal corticosteroid hormones, and glucocorticoids. And then you've got dexamethasone, which is a corticoid steroid, because anytime you have SO and E at the end of a medication, that's indicating that it is a steroid. You have immunomodulators, adrenocorticoid steroids, muscle relaxants, and immunosuppressants. So these are the type of medications that they would use for a patient with multiple sclerosis. So this is your at-home care. You want to do things like watch for visual changes. You're really looking to see, is my patient developing any sort of double vision? Are they developing that diplopia? Drinking fluids. So one of the issues with a lot of your MS patients is they will develop this neurogenic bladder, where they develop this, where they have urine retention, and it's difficult for them to actually urinate. They get nervous about it, and then they say, okay, I'm going to limit my fluid intake. Well, you don't want them to limit their fluid intake. So even though that they're scared that they might have this urinary retention, you do want to encourage them to still drink at least 6 to 8 glasses of water daily. So just encouraging them to drink. Stretching is good for them, so that way they can keep getting things moving. Gait training, making sure that they are appropriately using their assistive devices. Encourage them to use things like a cane or a walker, especially to conserve some of their energy. Have speech therapists on board with them. Once again, it's important that we have speech therapy, because they can lose that connection to be able to actually swallow appropriately. So you want them to have speech therapy on board. Respiratory therapists as well, if they're having a breathing problem. Removing stress. So removing stress, I've said this a lot for our autoimmune disorders. It's a very difficult conversation to have with the patient to remove stress. Some of the things you can do is, for example, if they're in a very high stress environment for their job, maybe telling them to seek something that might be a little less stressful, talking to their manager about managing that stress, especially if they work in a position that they can do it. Like, the one good thing about nursing is that we do have the flexibility to be able to change to different positions if we need to. So kind of having those very real conversations with your patient about, it's okay to not stay on this floor. It's okay to move to a position that's less stressful, less demanding. Their BMI, so making sure that their body mass index is kept within a normal range. So you want your weight at the recommended level for the patient's height and weight. So just making sure that we're keeping that normal range, so it puts less pressure on them. The next one we're going to talk about is myasthenia gravis. So myasthenia gravis is an autoimmune disease caused by the loss of functioning acetylcholine receptors in the neuromuscular junction. Most individuals with myasthenia gravis test positive for acetylcholine receptor antibodies. So reduction in the number of acetylcholine receptors causes ineffective neuromuscular transmission, which causes muscle weakness and easy fatigability. So acetylcholine is one of those neurotransmitters that helps with your muscle skeletal. So when we have this reduction of the receptor sites, then we're not going to have as efficient transmission, which leads into that muscle weakness. So all of this myasthenia gravis comes back to this muscle weakness. So commonly, the extraocular muscles, such as those that control the eyelids, are affected first. So the way I always remember it is myasthenia gravis, my eyes, because it usually starts with the eye drooping. So ptosis is the medical term for that drooping of the eyelid. And you can see it in this gentleman here, where he's got that droopy eyelid. The cardinal feature of myasthenia gravis is fluctuating skeletal muscle weakness, often with true muscle fatigue. Fatigue is seen as a worsening of the muscle contractility force. Patient can have blurred vision and unclear speech patterns. Once again, remember, it all comes back to our muscles. You can most notably see this with repetitive motions, such as when the patient's blinking, walking, or even talking. And a lot of times rest will improve this muscle function. So you want to assess respiratory function and gag reflex in patients affected with severe myasthenia gravis, as the diaphragm, intercostal muscles, and swallowing muscles can all be affected. Aspiration and respiratory failure are both major causes of death in severe myasthenia gravis. But yes, so with it, they may have difficulty articulating because once again, they have that unclear speech pattern, those visual problems, and I would definitely be watching for their swallowing. Ooh. Sorry about that. So for your diagnostics, a lot of times what they'll do is this Teslin test or the endrophonium. So what they do is they give acetylcholinesterase inhibitor, and what happens is it diminishes the enzymes that destroy acetylcholine at the neuromuscular junction, which allows more acetylcholine to remain in the synapses for a longer period of time, which improves the neuromuscular weakness. So basically what they do is they give them this Teslin, and when they give that to them, they immediately see a fixing of that drooping eyelid. It's just a diagnostic because the medication doesn't stay in long enough to actually fix the problem, but it's enough for us to see, oh yeah, this is myasthenia gravis. The other thing they can do is serum acetylcholine receptor antibodies and an EMG, which is an electromyography. And this is just a diagnostic procedure to assess the health of muscles and nerve cells. Because once again, this is a muscle autoimmune problem. Treatment, you can give acetylcholinesterase inhibitors. If rapid treatment is warranted, therapeutic options include intravenous immunoglobulins, plasmapheresis or plasma exchange, which removes acetylcholine receptor antibodies from circulation. You can remove the thymus, and the patient is usually seen by a neurologist. So yes. The next one we're going to talk about is Guillain-Barré syndrome. This is an autoimmune syndrome that causes acute peripheral neuropathy, which leads to progressive limb weakness over the course of several days to 4 weeks. Usually a positive infectious disease, with most of the patients having hold on. So what happens is they'll have a infection previously of either the upper respiratory tract or gastro tract. It has also occurred after immunization with various types of vaccines. So usually what will happen is they'll develop it after they've had some sort of illness or vaccine. Immune system overreacts to the infection and attacks the Millian sheath. So once again, we're seeing where they're attacking the Millian sheath, only this time there was some sort of infection or some sort of vaccine that caused them to attack it. So it's often referred to as ascending paralysis because it goes upwards. Sensory and motor nerve involvement, so it does involve those cranial nerves. It is progressive, usually symmetrical muscle weakness accompanied by absent or decreased deep tendon reflexes. Paresthesias and numbness are usually the first symptoms, and the weakness can vary from mild weakness in the lower limbs, causing difficulty walking, to nearly complete paralysis. Sorry. So what will happen is it'll have this progressive symmetrical muscle weakness. And it usually begins with this mild weakness in the lower limbs that can be difficulty walking, to nearly complete paralysis of all extremities and respiratory muscles, requiring support of artificial ventilations. So, like I said, it's often referred to as the ascending paralysis. So it starts at the feet and then it slowly moves up, and it can get all the way up to your cranial nerves. So it can affect things like your swallowing and gag reflex, because it's basically paralyzing this. Because remember, this is an attack of the Millian sheaths again. So you're looking for that decreased deep tendon reflexes. You're looking for those sensory or motor involvement. In the acute stage, you'll see things like weak muscles, sensory cranial nerves. So like I said, cranial nerve, they'll have that gag reflex, the swallowing problems. Symmetric weakness in lower extremities ascends to the upper extremities, torsals, and cranial nerves. And then in the stabilizing or plateau stage, you'll see that leveling off of symptoms. And in the recovery stage, muscle strength and function returns. So the first one, it can be very frightening for a patient because all of a sudden they can't feel their legs. They're losing all of this all the way up. And then finally we level off those symptoms and we kind of fix it. So for them, medications are usually for manifestations. So what you can use though is immunoglobulin therapy. And with that immunoglobulin therapy, what we do is we'll get that donated plasma, which contains healthy antibodies that won't attack the body's nerves in order to kind of help with this. Surgery, tracheostomy, or possible pacemakers. And then they can also have that plasmapheresis. With it, you have some different kind of diagnoses that you can do, things like acute pain related to muscle atrophy, risk for impaired skin integrity, and risk for ineffective breathing pattern. So you're kind of looking for different nursing diagnoses that can help drive your care. So this is the one I was talking about with how to remember Guillain-Barré syndrome versus myasthenia gravis. So both make you numb and you both lose muscle function with both of them. Both are autoimmune. The difference is my Guillain-Barré starts at the feet and moves up, while myasthenia gravis, like I said, my eye usually starts in the face and moves down. The Teslin test will show immediate brief improvement. So on this picture here, you can see the Teslin test that they did. That's before and that's after. It just doesn't stay long enough in the patient to fix the whole problem. So it'll improve their strength for about 5 minutes and then it's done. As always, thank you all.